Hola, ¿qué tal? Mi nombre es Luis Martínez y es un gusto para mí poderles dar la bienvenida a esta primera edición de la serie de pláticas con expertos en salud global. El día de hoy tenemos el honor y el privilegio de poder platicar desde Londres con el doctor Peter Piot, quien es una de las figuras más importantes de la salud global pues, alrededor del mundo. El doctor Piot es un médico investigador de origen belga especializado en microbiología y es conocido principalmente por ser uno de los descubridores del virus del Ébola en 1976 en Zaire y por fundar y dirigir por primera vez el programa conjunto de las Naciones Unidas para VIH-SIDA. En este momento, el doctor Peter Piot es director de la Escuela de Higiene y Medicina Tropical de Londres, también conocida como the London School of Hygiene and Tropical Medicine. Professor Piot, hi, how are you today?
I'm fine, thank you. It's a nice weather here in London, and happy to hear you, and mucho gusto.
Fantastic. Thank you so much for giving us today some minutes, Professor, some of your time, talk about global health and your experience as a global health champion. Professor, but first, we would like to start by knowing a little more about you. Could you tell us a little about yourself? Who is Peter Piot?
Well, I was born in Belgium in a small village in Flanders, and so Dutch is my mother tongue, and from already when I was very young, I wanted to see the world, and I was interested in science and in biology, and that led me to study medicine, and then I became more and more interested in infectious diseases. But when I was in my last year in medical school in Belgium, and I went to talk to my professors about my future career, what I specialty training. The verdict was unanimous: no future in infectious diseases. That's it. And that was okay, very bit discouraging. But on the other hand, I strongly believe that you have to follow your passion and you have to do what you really like to do, because that you will do well. So this is how I got an specialization in clinical microbiology. I did a PhD in microbiology, and while I was doing that, I was part of the team that discovered the Ebola virus, we isolated for the first time, and also I went to then for the first time in my life to Africa to investigate Ebola. And then a few years later, after having spent some time at the University of Washington in Seattle in the US, a new virus popped up in my life, and that was HIV. And again, we were seeing patients, this was in Belgium again, from Central Africa with what today we call AIDS. It did not have a name yet. But there was one big difference with what was reported then from the US, and that is that we saw 1/3 of our patients were women. And it was clearly a heterosexual type of transmission going on, and which I could confirm when I did further studies in Africa. And that was very exciting times, very sad times also, because there was no treatment, and people died. Nearly everybody with HIV infection would die. And I did a lot of research, particularly in Zaire, in Kenya, on heterosexual transmission from mother to child, tuberculosis and HIV, prevention methods. And but then I got a bit of a midlife crisis, and I said I cannot just continue to study this epidemic. I want to stop it, and I went to the World Health Organization for a while, which is probably the last place on earth if you want to change the world. But I really liked it, and I could see how you can influence policy. And then what was a 1-year sabbatical leave turned into becoming the head of UNAIDS, a new institution in the United Nations. I reported directly to Kofi Annan. The Secretary General was my boss, and my goal was to put AIDS on the world's agenda, and also to make treatment for HIV infection, antiretroviral therapy, accessible to all people in the world by reducing the price and finding financial mechanisms, and at the same time bringing people with HIV around the table, because I'm a strong believer that if you want to be effective in public health and probably in other fields as well, you need to talk to people, you need to listen to them, and you need to work with the communities. So that's in a nutshell. And now I'm in London at the wonderful London School of Hygiene Tropical Medicine, which is the United Nations under one roof, where we have people from all over the world, including from Mexico, students and staff, and we work together with so many institutions all over. And people here are passionate about public health and global health.
Thank you, Professor. Well, still global health is rarely defined, in particular in this part of the world. But from all the lessons that we have learned from epidemics like SARS and Ebola, and the new challenges like the ones related to migration, climate change, and planetary health, for example, how should we define global health these days?
Yeah, I hesitate to really define global health. It's been quite controversial in a sense. And for me, it's a field of inquiry and practice of health and disease, both. It's global health, not global disease, not like, and that are transgressing borders, that require solutions, that have a lot in common among countries. And it's based also on the fact that certainly when it comes to infectious diseases or to, for example, health problems linked to climate change and so on, there are no borders anymore. And but the reality is that global health is a new concept. When you try to find it out, when did it pop up for the first time? It was really around the millennium, around 2000. Before, very few references went to global health. And it was driven by the AIDS epidemic. With the AIDS, there was a new pandemic that was affecting mostly young adults. Not clear how to deal with it, the treatment, driven by not only by sex, but also by a lot of social factors, from stigma, discrimination, but also poor education, and then sexuality issues around homophobia and so on. And AIDS developed a quite original type of approach to, I would say, public health, but also medicine. It brought together prevention and treatment, which have traditionally in public health, we don't deal with treatment, and then medicine doesn't deal with prevention. And these two clearly have to come together. That is very important in public health. Also, a lot was driven by people living with HIV. So the voice of people affected, of patients, is very key here. So activism, and driven by human rights, the right to health, very, very important, equality, equity. But these are basic concepts in public health also, going back to the roots of public health. And I would say also the rapid adoption of innovation, of technology, be it a new treatment or new prevention ways. So that's also being, a very important factor for in terms of global health today. And I would say finally that it has led to far more international collaboration, finding solutions than ever before. For me, global health is not health only in countries far away, or in like tropical medicine where it's very hot, or international travel. It's not us, it's the others. It brings together the here and the far away in one concept, and that corresponds to our globalized world, and also to notions of the fact that no country, even the richest country, has all the solutions, and no country is too poor to offer solutions and to offer original approaches. So by this cross-fertilization, we can all get better.
That is correct. So you have been on the front lines fighting these two viruses, first Ebola and then HIV and AIDS. Professor, what should be the lessons learned from the experience of of your experience in UN/AIDS, and in particular, your experience also with the Ebola virus.
Maybe first Ebola virus, because we're in the middle of a big outbreak of Ebola. And I think the first lesson is that even at the time when in most countries infections are no longer the big health issue, it's chronic infection, it's chronic conditions, obesity, diabetes, and so on, we will always have epidemics of emerging infections. I think the biggest threat that potentially can come up is influenza, a pandemic. We are now about 100 years after the so-called Spanish flu, which killed between 50 and 100 million people on Earth. And one day that will come back. So we always will have these health emergencies, and we need to be prepared for that. That's one thing. But also, we cannot avoid that an outbreak starts, but what we can avoid is that and prevent that it becomes a big epidemic. And that's what we have to concentrate on. And the current outbreak of Ebola in Eastern Congo, Democratic Republic of Congo, has now already killed over 1,600 people. It's the second largest outbreak of Ebola since the West Africa outbreak, which killed 11,000 people. And the reason is that it's in an area that's highly populated, but also that has been suffering from violence, from violent civil unrest, from militias, and really brutal civil war and mistrust of government. And that makes it extremely difficult to bring this epidemic under control. So that's a very important lesson. You know, we can have all our technologies and vaccines and treatment and what have you, but if there's no trust in the community, if there is violence, if there is a humanitarian crisis, it's very difficult to promote health in general and bring an epidemic under control. With AIDS, I must say that maybe the most important lesson I've learned is that there is a very important interaction between science, politics, and action on the community and human rights. And, AIDS was so difficult to deal with in the early days, also in Mexico, I remember, that because of the stigma around homosexuality, the authorities and public health, community did not want to deal with issues around sexuality in general. That is very important, but we have, so that's the societal part, if you want. But the interaction is between science and politics is really important also. In the case of AIDS, we had fantastic developments, discoveries from antiretroviral therapy to pre-exposure prophylaxis to how to prevent mother-to-child transmission and so on and so on. That needle exchange prevents the transmission of the spread of HIV among injecting drug users. All that is very firmly evidence-based. However, to translate that into policy and politics, that's really challenging. And let me give you two examples, or three, let's say. One is that a very simple one, that even promotion of condoms save lives, that in many countries has become, it was very difficult for moral reasons. So that's the politics in the way of evidence. When we have, particularly in countries of the former Soviet Union, there are, the HIV epidemic is driven by injecting drug use. And injecting drug use, as I said, we know that by needle exchange and clean needles and syringes, we can at least slow down and sometimes bring to nearly zero a transmission of HIV in that community. It sounds counterintuitive, explaining to a political leader that in order to deal with HIV among injecting drug users, you need to give them more needles and syringes. And they say, oh my God, this is impossible, and we can't do that. And yet, it's evidence-based. And because this evidence has not been accepted in the countries of the former Soviet Union, starting with Russia, that they have an HIV epidemic that is one of the worst in the world now, where we have new cases all the time. And so here politics is in the way of public health. And third example is an extreme one of denialism, we would say today, fake news, when President Mbeki from South Africa doubted that HIV exists, that treatment is possible, and because of that, treatment for HIV infection, for AIDS in South Africa, was delayed by several years, and that in a country where there are now 6 million people with HIV. And that caused the death of quite a few people. So we have good politics, the ones that led to the leadership and development, the creation of the Global Fund to find AIDS, TB and malaria, courageous leaders taking on AIDS in their community or the country or even in a church, and then you've got bad politics. So, but frankly, this is true for anything in public health. Look at the moment at the fact that we have measles epidemics in so many countries, including in countries that were declared exempt from measles. And that's driven partly by logistic issues or supply, that the vaccine is not there, but also partly because of anti-vax movement, of fake news and so on. And it's amazing that in the 21st century, that one of the tools that we have in medicine and in public health, one of them that has saved millions of lives, that people are now refusing that. So it's never finished. That's also politics.
That's correct. It's never finished. And just talking about the main challenges that we have now, what do you think should be the main challenges of global health this century?
Well, first challenge I would say is to make sure that the unfinished agenda is being finished. And by that I mean there's still in many countries very high child mortality, maternal mortality, also in parts of, in Latin America, in poor populations, that's still there. And so the classic, let's say, infectious diseases that we need to make sure that they're being brought under control. For most of them, we have the technical means, but sometimes it has to do with access to healthcare, to facilities linked with poverty. When I think, for example, of maternal health. So that's the first thing, making sure that the whole world is not suffering from these infections that we can, wipe out. Secondly, there is now, thanks to, among other things, longer life, and also thanks to increase in wealth, we have now new diseases. We have chronic conditions, as we call it here at the London School of Hygiene Tropical Medicine, where we have a special center for it. Obesity, diabetes, Mexico is very much affected by that. Cardiovascular disease, some of it driven by, smoking is, by high sugar consumption, unhealthy diets, and so on. Lack of exercise, we know all that. But it's not so easy to combat. I think the easy solutions are over. It's not like you have measles and you can have a vaccine and you can wipe it out if everybody has a vaccine. But that's not the same thing, when we're dealing with these chronic conditions. Or mental health is also something that has always been there, but is really very neglected. So we need to design, programs, interventions, approaches that support people to remain healthy. So we live much longer, but the goal of public health can no longer be just survival and longer life expectancy. We need to think of better quality of life. So healthy lives, years, as long as possible. I always say I like to die healthy. And that means I like to get old, but I like to stay healthy as long as I can. And that requires new approaches where we involve not only our public health community. We know what works in terms of the technical side, but here we need to see sometimes regulation. Think of tobacco, but also work with the food industry. How can we provide healthy food that's affordable for everybody and that's tasty? I'm from Belgium. We like good food. How can we do that, and that on a large scale? That's a big issue. And then the third big problem for me is things that are linked to environmental degradation, the pollution that is really so dramatic in many of our cities, exacerbated by climate change. And, that is also going to have a major impact long term. I wonder, I have grandchildren and here in London, and many parts are very polluted, and and they go to school. What does it do to their brain, to their arteries, to their cognitive development in the long run, in long exposure? In addition to the acute impact of climate change, extreme heat, and pollution on people's health. So again, this is far away from our classic public health type of approaches, and we need to promote fundamental ways of living differently, and that goes against both economic interests, but also our way of living, and where we have a good life, and we're used to the car, to good food and all that. So it will be something that cannot be resolved by, let's say, state intervention alone or by public health interventions alone. We will need to make sure that everybody, every citizen, is part of that kind of movement.
Of course. Professor, well, finally, this talk will be watched by young health professionals, mainly in Mexico and Latin America. What message would you like to give them today?
I think that the health is going to become more and more important. We've made fantastic progress thanks to science and innovation and public policies and better health coverage and better education and wealth. But now we need to make sure that health professionals, that we are going to continue innovation, but that we also connect with other sectors to tackle these very difficult issues. And we always should speak truth to power. When we know that there is a big issue and we know what could work, but even if it's not popular, either with politicians or with businesses or with people, I think we need to tell the truth, and people need to see what are the consequences of how we live and what we do. And that's not always pleasant, but I think that's our responsibility. And I think it's still one of the most exciting fields. I'm also a strong believer that the golden age of public health, of population health, is coming, because we live so long. There's a limit to what medical care can provide in terms of quality of life. So we need to make sure that we all stay healthy. So that means prevention and population health.
Fantastic. Professor, well, thank you one more time. Thank you very much for your time. And we know you have a busy schedule, and we really appreciate just the minutes that you share with us today. Please receive from all the team of the Mexican Society of Public Health and the Carlos Slim Foundation, well, our best wishes to you, your family, and the amazing team at the London School of Hygiene and Tropical Medicine.
Thank you very much. A real pleasure, and good luck to everybody working on public health in the Americas.
Fantastic. Have a good day, Professor, and our best wishes to London, from Mexico to London.
Thank you.
Thank you.
Adios.